Hello, my name is Jordan Torres. I'm a second year internal medicine resident with HCA Houston Healthcare and University of Houston. And I'll be presenting this case, cryptococcal meningitis, presenting as unremitting headaches in a young patient. So a little bit of background about my case. This cryptococcal neoformans is a fungus, typically infects immunocompromised individuals via inhalation, typically soil that's been infected by bird droppings with the fungus. And it can disseminate in the CNS or cause a pneumonia-like disease. So some risk factors include all about immunosuppression, HIV with CD4 count less than 100, solid organ transplant, hematologic malignancy, long-term steroid use, or uncontrolled diabetes mellitus. There have been a few previously reported cases of immunocompetent individuals developing this, but they had risk factors such as farming, being around a bunch of species of birds, active military with a lot of international travel, or chronic inhaled marijuana use. So to start things off with our case, it's a 22-year-old female who presented to the emergency department with a 16-day history of intractable, sharp, throbbing headaches. Patient had a history of chronic migraines after a motor vehicle accident and initially attributed it to migraines, but it didn't get better with her over-the-counter medicine. She reported subjective fevers, nausea, phonophobia, and intermittent left-sided hemiparesis. Patient resides in East Texas, no recent travel, up to date on all vaccines, smokes 1 to 2 cigarettes a day, and denies any alcohol or recreational drug use. At the time of physical exam, she was afebrile, stable vital signs. She had neck stiffness on flexion and extension, and right upper lower extremity paresthesias. CBC and CMP were within normal limits. CT head showed no acute intracranial process. So an MRI was obtained at this time, not concerning for meningitis, but more for her migraines that changed in quality and with new neurologic deficits. When we saw the MRI, it came up as this leptomeningeal enhancement in the left parietal occipital lobe. Lumbar puncture was then obtained, which showed an opening pressure of 62, white cells of 171, and glucose of 29, and normal protein. Her symptoms also significantly resolved after lumbar puncture, so at this time, amphotericin was started, and preliminary CSF gram-stain grew encapsulated yeast, and cryptococcal titers in this CSF was positive. She was then continued on liposomal amphotericin and eventually transitioned to flucytosine in the outpatient setting. Her HIV, hepatitis, RPR, ANA, rheumatoid factor, and HSV were all negative. CD4 count was also normal. So this patient was managed with the serial LPs, had a PICC line placed for amphotericin and flucytosine, and discharged with close follow-up and recovered well. So to discuss this case, her symptoms at onset initially didn't ring the bell for meningitis due to the time course, but is more typical for fungal or tuberculosis with this type of presentation. And at 22 years old, the patient is the youngest reported case of cryptococcal meningitis in an immunocompetent patient, and has no risk factors for immunosuppression. The next youngest patient reported was 23 years old with chronic hep C and IV drug use. And then in other immunocompetent patients in the literature showed risk factors such as what we alluded to previously, a farmer around multiple species of birds, a patient who had daily inhaled cannabis use, and a patient who traveled extensively in the military. So to further rule out immunosuppression, the patient will need close outpatient follow-up for further diagnostic testing. The thought is that there is some type of immunosuppression going on, but we just haven't been able to identify it. And also to discuss this MRI use, it's not a routine test in meningitis workup, but was obtained due to her history of chronic migraines with new focal neurologic deficits. And so to conclude, cryptococcal neoformans, this can present in young immunocompetent patients as subacute headaches and focal neurologic deficits. So an MRI with leptomeningeal enhancement with these types of symptoms should really consider cryptococcal meningitis high in your differential. Thank you all so much for your time. I hope you enjoyed the case.